structural part, and we invite Dr. Rashmi DESHMUKH to please talk about the management algorithm for ectatic corneal disorders.
Good morning. I'll be talking to you all about ectatic corneal disorders and how to manage them. So initially we'll just look at what is corneal ectasia and keratoconus. So in corneal ectatic disorders, essentially there is corneal thinning and which causes visual impairment because of the corneal shape distortion, because it's no more able to hold its own shape. So it can be diagnosed with the help of corneal topography scans, where you'll see keratometric steepening, inferior irregular steepening in the keratometry maps, anterior and posterior elevation, which is usually coincident with the thinnest point on the cornea. Sorry, yeah. And usually keratoconus and other corneal ectatic disorders are monitored for progression. If on the comparative scans over 3 to 6 months, the corneal topography does not change much, then it is called as a stable disease. But if you see that there is progressive steepening in the area of the cone, then it is known to be a progressive disease, and that itself requires the treatment for stabilization. Why? Because it is known to affect visual acuity. So sometimes the visual acuity itself can reduce over time because of a progressive disease, or visual acuity can be maintained, but the quality of vision because of progression is going to reduce over time as well. So this is a broad overview of the management of keratoconus. Within 15 minutes, it is not possible to cover everything, so I'm going to give you a broad overview of things. When we are managing a corneal ectatic disease, we are mainly concerned of two things. One is we want to manage the progression itself. Second is we want to manage the vision of the patient. So for progression, we are going to look at collagen cross-linking. If the patient is not suitable for C3R, then usually we go ahead with a keratoplasty. And for vision, we start with spectacles or contact lenses. If it is mild to moderate, then usually you can perform procedures like PRK with C3R or ICRS combined with C3R, which can help in corneal regularization. And if it is more advanced, then stromal keratophakia has come about for corneal regularization, but I'm just going to touch upon it. So first, corneal collagen cross-linking. Before C3R started for keratoconus, it was only contact lenses and keratoplasty which was used. There was nothing in between. So if contact lenses are not giving good vision, we would directly do a corneal transplant. But it was known that the total collagen content of the cornea does not differ in keratoconus as compared to a normal cornea. It is only the corneal stiffness which is reduced by almost 70%. So that is how the concept of collagen cross-linking was developed. Normally also cross-linking is seen in a normal cornea with increasing age, with diabetes, which causes increased glycosylation, and with increased exposure to ultraviolet light. And what it essentially does is it increases the biomechanical stiffness of the corneal collagen. So it is making the cornea rigid so that it does not progress further. So what is the procedure itself is that the cornea is soaked with riboflavin and there is ultraviolet light exposure for at least 30 minutes at a dose of 3 milliwatts per centimeter square to achieve a total surface dose of 5.4 joules per centimeter square. This causes a biochemical reaction between the photosensitizer, which is the riboflavin, and the ultraviolet light. It can be an aerobic and an anaerobic reaction, which causes formation of covalent cross-links between the collagen molecules as well as within the collagen molecules itself, meaning between the fibrils. So the initial standard protocol which was described was the Dresden protocol, where like I just showed 3 milliwatt per centimeter square of ultraviolet light is given for 30 minutes after riboflavin soakage. But it was seen to be endothelial toxic, and it was told that it is safe only for corneal thickness up to 400 microns, which was the corneal stromal thickness for the safety of endothelium, which was prescribed. When one should cross-link is in a progressive cone. So if there is an increase of 0.5 diopters or more in 2 or more keratometry values in the steep meridian between two curvature maps that you are seeing in consecutive visits, but there is no corresponding area of flattening, that means the cone is progressing. And another criteria which is commonly followed is you look at the maximum keratometry value, and if it is increased by more than 0.5 diopters over 6 months, then you can go ahead for a cross-linking. But sometimes you might not want to wait for a comparative scan, and you might not want to wait to see progression. That is when a patient is presenting at a very young age, because they will be at a higher risk. You should also look at the grade of keratoconus, how advanced it is, and the corneal pachymetry, whether it is borderline, you might not want to wait ahead. Then certain risk factors like VKC or patients with developmental delay, you might want to cross-link in the first go. Again, depending on the other eye status as well, if the patient is one-eyed or if the other eye has had high drops, then you might want to cross-link in the first go. And if the patient is not available for follow-ups, is another time when you could consider cross-linking in the first visit itself without waiting for actual progression. Now, apart from resident protocol, there are accelerated protocols as well, which are based on Bunsen-Roscoe law. What is this law? Is that it's a photochemical reaction is directly proportional to the total energy dose, irrespective of the time for which the dose is delivered. So here the total surface dose that we want to achieve is 5.4. In resident protocol, we are giving 3 milliwatts per centimeter square for 30 minutes. In accelerated protocols, you are giving, the commonly followed one is the 9 milliwatts for 10 minutes or the 18 milliwatts for 5 minutes. And it still gives the same surface dose that can be achieved, but it saves some time. Now, there are different CXL machines which are available for collagen cross-linking, which can achieve certain doses. And your protocol might depend on the machine that you're using as well. What is expected post-op is the corneal stabilization, and at times corneal flattening is also seen over time. And on OCT, one can see a demarcation line like this, which is actually used as a surrogate marker for the depth of CXL effect, but it should not be taken as the actual depth at which collagen cross-linking has happened. It can only be used as a surrogate. So this was the basic about collagen cross-linking, which helps in stabilization of the disease. But for corneal regularization, it can be combined with either PRK with C3R or ICRS with C3R, which is intracorneal ring segments. So first, looking at intracorneal ring segments, they were FDA approved for the use of keratoconus in 2004. Before that, they were used only for mild myopia. So how do they work? In ICRS, they are basically spacer elements which go between the collagen fibrils or the collagen lamellae, and they have an arc shortening effect like you're seeing in the picture above. And it is based on the Barreker thickness law, which says when you add material to the periphery of the cornea or you remove an equal amount of material from central cornea, then you're going to have a flattening effect on the corneal curvature. So again, this is a figure to show how the ICRS reshapes the cornea. It creates an artificial limbus within the cornea. So, and there is a redistribution of the biomechanical stresses, which is more even after the ICRS, and it is expected to cause an improvement in corneal regularity and tomography. And the amount of flattening and regularization that you are going to get depends on the optical zone where you're placing it and the thickness of the ring. The shorter the optical zone or the smaller the optical zone, the more flattening you're going to get, and the thicker the ring, the more flattening you're going to get. Now, intracorneal ring segments are of 3 types. One is Kera rings, then you have Ferrara rings, and then you have Intacs. For all practical purposes, we'll be talking about Intacs henceforth. So in Intacs, there are usually semicircular pieces of PMMA, which are around 150 degrees of arc length. And they are seen as you see in the image like that. You can either place a single ring or you can place a double ring based on the corneal topography. When you should use is that you should have a clear optical zone. There should not be any central scarring. It is usually good if the mean keratometry value is less than 58 diopters for regular rings. For 58 to 62 diopters, steep K rings are also available. It's not like you can't do it beyond 62 diopters, but the amount of flattening is going to reduce the steeper you go. The minimum pachymetry in the 6 mm zone should be at least 450 microns. This is because you want adequate depth for the Intacs channel to go in, and you should not have any perforation, so you should not go thinner than that. And it is usually used in patients who are contact lens intolerant. Which are the poor candidates for placing ICRS when there's central corneal scarring, when the cases are still progressing, where you are still unsure about what the astigmatism and the axis is going to be. Pachymetry less than 450, like I just mentioned. And of course, we have to set realistic expectations with the vision, because this is just going to improve the visual quality and reduce the astigmatism, but this is not akin to a refractive surgery where the patient is going to get rid of the glasses. This is such that the cornea gets regularized because the patient is contact lens intolerant, so he can at least get some vision with glasses. So while planning, the ideal position of the incision is on the steepest corneal meridian, and it reduces corneal power of the steepest meridian to cause an increase in the flat keratometric reading. And the depth of insertion is usually 70 to 75% of the total corneal thickness at the incision site, which is at the 6 mm zone. It is usually recommended to stay at least 90 microns away from the endothelium to cause any damage. The channels can be created either mechanically or by femtosecond laser. And this is just a video to show how it is actually inserted. So here the femtosecond laser is creating the channel, and this is how the incision is made on the steep axis. Then once the incision is made, it is usually opened up using a Y spatula. So you open up the incision, and then this is so that you initiate the insertion of the Intacs rings. Then you hold the ring perpendicular so that you go into the depth of the channel and you don't cause a false passage, and then you start pushing it into the channel. Once it is adequately inserted, then it goes in easily if you just push it parallelly to the corneal surface. In the end, you can choose to suture the incision side, or you may leave it unsutured, but you should put a BCL then on top to prevent any migration of the Intacs rings. Here I've put a suture. Just an example of how a double ring would look, and in corneal topography, so the middle picture that you're seeing is the pre-op, and the first topography is the current picture. So you are going to see a corneal flattening and regularization within the area where the Intacs rings were placed. That is what is expected. When you combine it with C3R, the mean change in sphere expected is up to 5 diopters with a mean change in cylinder of up to 2.5 to 3 diopters. So this was the basic about ICRS. Now coming to PRK with C3R, again another thing which is combined with C3R for corneal regularization, which comes under the vision management category. So this is used again only for corneal regularization, not for not like a laser vision correction. You need to make sure that you have adequate corneal pachymetry, usually more than 450 microns, and you should have a residual stromal thickness of at least 350. We have to keep in mind that these are already weakened eyes, so we need not correct the entire corneal power refractive error and weaken the cornea further. Post-operative corneal thickness at least should be 400 microns, which would include the epithelial thickness as well. To see the target refraction, how you are going to plan the ablation, emetropia is never the goal, and that should be explained to the patient. And we have to keep in mind that cross-linking itself also causes some amount of flattening. So an undercorrection by at least 20% to 40%, depending on the protocol that you're using, is expected, because standard or resident protocol is going to cause a little more flattening than an accelerated protocol. And visual improvement is usually seen better with central cones as compared to eccentric cones. When is the collagen cross-linking done? In PRK with C3R, it is done immediately after PRK. In Intacs with C3R, it can be done at the same time, or it can be done sequentially. But in this case, you have to do it at the same time. You can use either accelerated or standard protocol. It can cause flattening of curvature post-op. And PRK should not be performed in an already cross-linked eye, because like I was mentioning, these are already weakened corneas. So you don't want to ablate a cornea which is already stiffened up. You don't want to remove any tissue further. So just to give an example again, the middle one is the pre-op photo, and the post-op picture is the first one, topography. And you see that in the area of cone, we are causing a flattening to eventually cause an improvement in the visual acuity. The cylinder is slightly reduced in this case. And then once collagen cross-linking and Intacs and PRK are ruled out, there would still be certain cases which are not okay for collagen cross-linking because of the advanced nature of the disease and the corneal thickness which is available, such as this case where you can see that the corneal pachymetry is too low. Sometimes it can also happen that the corneas are too scarred, so even if you have a good thickness, you might want to go ahead for keratoplasty. So in keratoplasty, there is either an anterior lamellar keratoplasty, usually we go for a DULC procedure, or we can go for a penetrating keratoplasty procedure. This would be based on the level of scarring and the level of the disease that the patient has come with. If your scar is more anterior, like you have an apical scarring, then you might want to go for a DULC, because you will easily just remove the stroma and you can still have a clear cornea. But penetrating keratoplasty is usually considered if the patient has had eye drops before. There is one more lecture on lamellar corneal surgery, so this will be covered in detail hopefully in that. So overall, this would be the management of keratoconus algorithm. So it would depend on whether your cornea is progressive or non-progressive. If it is non-progressive, then you just need to manage the vision of the patient, which could be with spectacles or contact lenses. If the spectacles or contact lenses are not adequate, you could go for either keratoplasty or Intacs. If the vision is adequate, then you just keep monitoring the patient for progression. As long as the patient is stable, you just keep managing the same vision. But if the patient progresses, then you look at what the corneal thickness is. If the corneal thickness is adequate, you could go for C3R combined with any of the procedures like I described. If the progression has caused corneal thinning and you're not able to perform a C3R, then you might want to consider a keratoplasty. Thank you.